I now want to hand over to Professor Sir Robert Leckler, Vice Principal Health at King's and President of the Academy of Medical Sciences, to introduce our next session. Robert.
Well, good afternoon and welcome to this first, I think as far as I know, this is a first, to have a joint venture between the Academy of Medical Sciences and the Association of Physicians. And it makes sense because we have a common interest in fostering and even strengthening academic medicine. So I think it's a very logical thing for us to be doing. And when this notion started to take shape, I think, if I remember correctly, David and I put our heads together and felt that, I thought the symposium was advanced therapeutics. I see it's down as targeted therapeutics, but whichever you want to call it, that this theme would be appropriate and timely. And I think that's true for 4 reasons. The first is that in terms of new therapies coming down the pipeline, a large fraction of them are in this category of advanced therapeutics: biologics, cells, genes, gene-modified cells, and the like. So it's a very important area from that point of view. The second is that it's a domain of activity that I think the UK is really strong in and really competitive in, something we should celebrate, but equally something, and we'll perhaps get to this in the discussion at the end, that we should think about how we can further accelerate our progress and strengthen our position. The third reason is quite relevant to the life sciences strategy part of the industrial strategy. So I'm sure you'll all be aware of the government launching an industrial strategy, and a key plank of that will be the life sciences. And in that context, advanced therapeutics is looming large and indeed identified as one of the lead themes that we should seek to further invest in partnership with industry. And the fourth and final reason is quite simply that it's a very exciting area. And so in trying to stave off your postprandial slumber, what better than to talk about advanced therapeutics? So those are the 4 reasons I think that this is a logical choice. I've been asked to mention the fact that this session is being filmed, and that, I suppose, is to encourage good behavior because it'll be captured on camera. However, the film will be edited, so if there is bad behavior, we'll just simply edit it out. The film will be available at some point in April to the members of the Association of Physicians, and we'll have to think about, because I believe there are a number of members, fellows of the Academy here who are not members of the ASPHIS, so we'll think about how to deal with that downstream. But you are being filmed. So the good news is that we've got 4 nationally leading figures in the field to talk to us in the next little while. They're each going to speak for around 20 minutes. We'll then have 5 minutes of questions specific to the topic they've discussed, and then that should leave a little time at the end for a slightly more general discussion about how we can make this field work better, move faster, and those sorts of things. And David, I think, will step in and lead that discussion. So that's the menu, the agenda, and it's a pleasure then to introduce our first speaker, Bobby Gaspar. Bobby is a professor of pediatrics and immunology from the Institute of Child Health and works in Great Ormond Street, and has been a leading light since the 1990s in gene therapy, and particularly the application of gene therapy for children. Bobby, over to you.
Thank you. Thank you very much, Robert. David, thank you for the invitation to talk. So I'm going to talk about the work that we've been doing on these, on developing gene therapy, not just for immune deficiencies, but where that field is going as far as developing gene therapy for bone marrow disorders as well. And I've titled it The Development of New Genetic Medicines because there is a move to make these licensed medicines, and I hope I can show you how some of that is actually progressing, and that also plays into to what Robert was saying about the industrialization or commercialization of these products as well. And in relation to that, some of the work that we've done has been incorporated into a commercial entity. So this is a slide that I drew up some time ago now, In fact, actually, I didn't draw it. I just found the picture. But it was a slide that I made 10 years ago when it was about what could happen as far as gene therapy was concerned. What could gene therapy do for various different inherited genetic disorders? And actually, I wasn't trying to be prophetic, but all of these are now in clinic. So all of these have actually made it into clinic, and some of these are having really very dramatic effects. So I'm not going to pick all of them out, but there are now single administrations of an adenoviral associated vector that can correct hemophilia B and A. So a single administration of this virus incorporates itself into the liver and produces factor VIII or factor IX, and individuals are recombinant factor independent as a result of that one administration. That is a transformative change for that disease. An administration of a similar vector into the retina of the eye is able to restore photoreceptor function so that individuals have improved sight, again, as a result of this one administration. So there are really some very dramatic changes afoot as a result of these kinds of interventions. What we've looked at is correcting bone marrow disorders, and we started off with these severe immunodeficiencies, and again, single administrations of corrected bone marrow stem cells are able to correct an individual for their lifetime, and that is something that I'll demonstrate in my talk. But the expertise and the technology that has been developed in these severe immunodeficiencies is now being applied to other disorders of the bone marrow, including lysosomal storage diseases, of which there are many, and also hemoglobinopathies, which are not rare diseases at all, but of course affect thousands of individuals worldwide. And you'll also hear about how gene-corrected T cells are able to fight acute leukemias, and I think John will be talking about that later on. So this is where we started. We started with conditions with very high unmet need. And these are children with severe combined immunodeficiency, where a single gene defect in the bone marrow gives rise to a loss of the development of immune cells, or immune cells that develop but do not function effectively. And these individuals are susceptible to all kinds of different infections, bacterial, fungal, viral, and these children will die in the first year of life without any effective intervention. The molecular defects that lead to these conditions have been now identified, and numerous genes have been identified, and they give rise to abnormalities of development of these progenitor cells. And I'm going to talk about two specific molecular defects. This is the common gamma chain, which gives rise to the X-linked form of SCID, and the ADA gene, which gives rise to the ADA form of severe combined immunodeficiency. And together they form about 40 to 50% of all the different types of severe combined immunodeficiency. And these are the two genetic forms where we have targeted gene therapy. Now, the conventional treatment for these conditions is a bone marrow transplant. So an allogeneic bone marrow transplant, taking marrow from a matched, or in some cases not so well matched donor, and giving it to these individuals. And where we have a very well-matched donor, usually a sibling, or in some cases a family relative, then we can get over 85 to 90% survival. But when you use unrelated donors, or you use mismatched donors, or family donors who are mismatched, then the survival rates are much worse. And even now, even in the best case scenario, we would say that a bone marrow transplant still has a 10% mortality. In cases where you use unrelated, it would be about 15 to 20%. With mismatched, it's down to 25% or so. This is historical data from Great Ormond Street. Why use gene therapy? Because you have the perfect match. It's the child's own cells, can't be rejected, can't give rise to graft versus host disease, which is the major problem with allogeneic transplant. Also, in these conditions, we can give gene therapy with significantly reduced amount of chemotherapy. So we avoid the short-term and the long-term toxicities associated with chemotherapeutic conditioning. So we think this was going to be a safer procedure, but can it be as good in terms of promoting immune reconstitution? And so this is the condition that we started this at. This was the first condition, the first monogenic condition that was ever corrected by gene therapy. And this is a disease where it's the X-linked form of SCID. It's a defect in a cytokine receptor complex. So this is a subunit of the cytokine receptor complex for actually a number of different cytokines, R2, 4, 7, 15, 21, and it gives rise to the severe immune deficiency. As a result of this, T cells don't develop, NK cells don't develop. The idea is really, very simply, take bone marrow stem cells, introduce a working copy of the gamma chain gene into those stem cells so they now have the correct signal to be able to develop T cells or NK cells. The kind of biomarker of success is very simple. These kids start off with no T cells, and therefore, if this works, we should see T cell reconstitution. And that is what we saw. So here in this trial, which we started in 2001, 10 patients, we took stem cells, we introduced a working copy of the gene into those cells using a disabled virus, and then we returned those cells back to these patients without any chemotherapy conditioning. In fact, some of these patients were almost treated as outpatients. They received their treatment and they went home again. We followed them up as outpatients. So all of these patients start off with very few T cells, and as you can see, all of them have increased T cell recovery. Now, this has been published a long time ago, and we've shown that those T cells are functional T cells in terms of proliferative capacity, in terms of their repertoire, in terms of going through thymic reconstitution. So this was very successful, held a huge amount of hope for other diseases. A similar study was conducted in Paris by Alain Fischer and Marina Cavazzano, which showed very, very similar results. First patients, as I said, in Paris were treated in 99 at Great Ormond Street in 2001. In 2002, there came these adverse events, these leukemias, in patients in Paris. In 2 patients in Paris, they were identified as having leukemias, and they were T-cell ALLs. When these were investigated, it was found that the leukemia, the initiating event in the leukemia was as a result of vector integration. So these vectors integrated into the genome, and what was found in these leukemic clones was the vector had integrated near a known proto-oncogene known as LMO2. The vector had turned on LMO2 in a non-physiological fashion. That had driven the abnormal cell cycle in these cells, which had then accumulated other genetic lesions and gone on to a transformative event. But the initiating event was the turning on of LMO2 by this vector. So obviously this caused a huge amount of problems for the field. It set the field back. These vectors, which we thought would be able to promote immune recovery, were giving rise to these kind of adverse events. And a lot of work went into understanding why that was actually the case. And this is the design of the vector. This is the vector that was causing the problem. So these are taken from gamma retroviral vectors. The inherent genes of the vector are stripped out, and we put in place a transgene that we want to express this common gamma chain gene. But the promoters are still the promoters of the gamma retrovirus, and they have these long-term repeats, which have powerful enhancer sequences. So when this vector sits next to an oncogene, these enhancer sequences are able to turn on the neighboring gene. And in the case of LMO2, it was turned on in an aberrant fashion. So an awful lot of work went then into redesigning these vectors. In fact, some people just said, we're not going to touch this any further, but others went on to say, well, can we redesign these vectors? And that's what happened. So we went in to design vectors where these LTRs were now deleted and were no longer active. Those enhancer sequences were removed. You still have to transcribe your gene, so you have an internal promoter that now allows transcription of the gene. And then in vitro studies, in vivo studies were performed in head-to-head comparisons, which showed that even if these vectors, this new design of vector, if it sat next to an oncogene, it couldn't turn the oncogene. So in vitro models of transformation, in vivo models of transformation, the transforming capacity of these vectors was significantly lower than these vectors. So we then went back into clinical trials using this new design of vector. The backbone vector was actually changed as well. We used gamma retroviral vectors in early studies, but we went to lentiviral vectors for future studies. So the lentiviral vectors based on HIV-1. So in this study, using a gamma retroviral vector, but with a new design, with this self-inactivating design, we were able to see, again, immune reconstitution, immune reconstitution that was very similar to what had been achieved previously, but now 6, 7 years after the first patient had been treated, there have been no clonal proliferations, there have been no expansions, there have been no leukemias. And if we look at the molecular signature in these patients, we can't see any evidence of clones emerging with insertions and integrations near LMO2 or other oncogenes. So it seems to be considerably safer than the vectors that we had been using previously. Now, this is the other condition, ADA deficiency. So this is a condition, again, it's actually a metabolic disease. ADA is expressed in all body cells. But in hematopoietic cells, as you break down your DNA, deoxyadenosine has to convert to deoxyadenosine. ADA catalyzes that step. In the absence of ADA, builds up deoxyadenosine and also deoxy-ATP, which are toxic to lymphocyte proliferation and maturation. We had actually done a gamma retroviral vector study with this disease, in this disease first of all, with some success, but with the adverse events that had been seen in X-linked SCID and actually in other immune deficiencies, we decided to go to a better, safer vector format. And so we designed an HIV-1 vector where we strip out the HIV genes, and we now express a codon-optimized version of the ADA gene under the control of a cellular promoter. So these promoter elements of HIV have been deleted. We took this into in vivo systems. We were able to show reconstitution in a murine model. We showed that T-cell development, B-cell development was equivalent to that using other vectors and also due to standard transplants. We then undertook an in vitro study where we look at transformation potential of this vector. And essentially what this involves is taking murine stem cells, infecting them at a high copy number with your test viruses, and then growing them out and look to see whether they actually have the capacity for transformation. With the old vectors, we could see a high level of transformation capacity, but we couldn't introduce any transformations with the vector that we had developed. This was then taken into clinical studies. We developed this with a group at Los Angeles, at UCLA, but with the same vector, using very similar protocols. We conducted a study in London and a study at UCLA. Endpoints were survival at 2 years and also looking at immune reconstitution. The vector was made to clinical grade at the Indiana University Vector Production Facility. These are now the results from both London and from UCLA. And these are the geometric means of now 30 patients that have been treated between the two centers. So when we put this together, we had no idea how closely the reconstitution would actually overlap between the two centers. But you can see in blue from the US and green from the UK, you can see the T-cell reconstitution in these individuals, in CD4s, in CD8s, and in CD19s as well. What happens to these patients as far as their clinical outcome is concerned? All of these individuals come into the procedure on enzyme replacement therapy. So we then give them the gene therapy procedure, and then we stop enzyme replacement. We look for immune reconstitution. So in fact, in all the US patients, they've all been able to stop enzyme replacement therapy, and only one of the patients treated in London has had to go back onto enzyme replacement. So in terms of efficacy, it's been extremely encouraging. So this is as a result of that one-off gene therapy procedure alone. They've got T-cell reconstitution, they've got B-cell reconstitution as well, and in fact, these patients are all stopping or are scheduled to stop immunoglobulin replacement therapy. And the one patient who had to go back onto enzyme replacement therapy is also the one patient who has remained on immunoglobulin replacement. So we've got both T-cell recovery and we've got B-cell recovery as well. Now, we don't often see survival curves like this when we do transplantation, but this is the kind of survival curve that you want to see. So all of these patients have survived this. It's not a curve, it's just a flat line, so it's good. Now, if we'd done a conventional, if we'd put these patients through an unrelated donor transplant, which would be an alternative, it's about 70% survival. So we've got a stage now, October 2016, 40 patients treated. Now, that isn't, for those of you in more common diseases, that sounds like a very, very small number. For the kind of disease we deal with, that's a big number. So 40 patients treated. Survival, all of those have survived. One patient back onto enzyme replacement. No evidence of persistent clonal dominance individuals when we look at molecular marking. Where do we want to take this? Well, we wanted it to be a standardized therapy. We want it to be a standard therapy when children do not have a matched sibling donor available. These kind of guidelines we've put together with gene therapy now as the standard treatment if no matched sibling donor is available. So we can do this for X-linked SCID, we can do this for ADA SCID. There are murine models that have been corrected for other forms of SCID as well. So there's recombination defects, RAG1, RAG2, and Artemis. There have been murine models that have been corrected, and those are now going to be taken forward to clinical studies. So there will be a gene therapy option for all the different forms, or the majority of the different forms of severe combined immunodeficiency. I'm just going to talk very briefly about another condition as well, chronic granulomatous disease. This is a condition where neutrophils form, but they do not have the functional NADPH complex to be able to kill bacteria effectively. And this component gives rise to the X-linked form of the disease. Again, we've taken that forward with a novel vector that has been developed in our lab. There is now a conditioning protocol in order to make space for gene-corrected cells. I'm just going to skip that and go to this patient here that we treated last year. These are all the clinical problems that he had, significant clinical problems. This child was on intensive care 3 years ago. We were thinking about whether we should continue treatment or just stop at that stage. He recovered from that, fortunately, and then he went into this procedure. And last July, we took cells, we corrected them, we gave him chemotherapy, we gave those cells back, and now, 8 months after the procedure, he has 31% functional neutrophils in the periphery. He's been able to repair his anal fissure, he's gaining weight for the first time, he has cleared infections from his chest and is going back to college. And that's been repeated in 4 other patients worldwide now and is going on to a much larger study. This is a slide not prepared by us, but prepared by Alain Fischer in Paris, where he shows the number of patients that have now been treated. We have 130 patients in different immune deficiencies. The overall survival is over 95% with excellent efficacy in those populations. These are trials that we conducted in the US and also in Paris as well. Finally, just to say, this is not just for immune deficiencies, but is now going on to treat metabolic diseases, and also in the New England Journal that was just a couple of weeks ago, gene therapy, bone marrow gene therapy for a patient with sickle cell disease. There's a whole list of diseases that are amenable to this form of gene therapy: immune deficiencies, lysosomal storage diseases, and hemoglobinopathies as well. These are the first cures for specific SCID conditions and metabolic conditions as well. They were the first cures with gene therapy. The mortality and the morbidity, when you think of the kind of innovations that we've seen previously, are extremely low. How did bone marrow transplant start? How did organ transplant start? What were the mortalities in those early studies? And if you compare that with the kind of mortalities and morbidities that we're seeing now, it's extremely low. We still need safer vectors. We still need to look at individual, the way those genes are regulated before we go into clinical studies. This can be done in an industrialized fashion whereby cells are taken rather than patients, and cells are taken to central manufacturing facilities, corrected, cryopreserved, quality control and conducted, and then cells shipped back to patients to be infused at the bedside. Will they be future gene therapy medicines? There's already a gene therapy medicine like this. So GSK have actually taken one of these products, a gamma retroviral vector for ADA, from Milan, and that has got approval as a licensed medicine. There are a number of other industrial entities that have formed who are trying to do this for beta thalassemia and sickle cell, for lysosomal storage diseases, for Fanconi's anemia, for other immune deficiencies as well. And so I'd like to end there and just really thank the enormous group that I've been able to do this, both scientists in the lab, our clinical nurses, our clinical colleagues, and also a huge number of collaborators worldwide, including this excellent collaboration with UCLA. And that's my partner, Adrian Thrasher, with whom I've worked over the last 20 years, bringing these to the clinic and to the funding bodies who have supported us. Thank you very much.
Terrific. It was fantastic work, Bobby. Thank you very much, and really clear. And just to reinforce the point you made, I think Roger Williams may correct me, but I think Tom Starsel's first 6 liver transplant patients died, and any normal ethics committee would have shut the program down. Fortunately, they didn't. And it's now a treatment. Different times. Yeah. Okay, a few minutes for questions. Could I just kick off with one, which is, To what extent are these kids chimeras in terms? So I don't know how severely you condition them. So do they have their defective stem cells producing some lineages and?
So there's a very powerful survival advantage for gene-corrected cells. So in the periphery, all their T cells are gene locked. They wouldn't get T cells if they didn't have a gene in them. So that's also the case in other lineages as well. So in lineages where there's not a powerful survival advantage, it is a mixed chimera. So for example, in the B cell lineage in X-linked SCID, it's part gene-corrected and part not gene-corrected. But because there's no dominant effect of the negative population, then that doesn't seem to matter. In the bone marrow, it's variable, but it's anywhere between 10 to 30% CD34s in the bone marrow are gene-corrected, but as they develop into H3, the survival advantage, it becomes a full lineage correction.
The rules have changed. I don't need to write down the names of people asking questions without them telling me who they are. That was days gone by. Sanjeev.
Thank you very much. That was lovely. Just a quick question that I think reflects probably the impatience of the families that you have to deal with, as well as the wider community. How long will it be before this sort of approach that you've described will become the standard of care, against which, for example, bone marrow transplantation becomes a second-line intervention? How long do you think you need to wait, and how many numbers do you need to accumulate before that happens?
It's a very interesting question. So, I've worked with my bone marrow transplant physicians, and we work very closely side by side. When we first started this, there was always a bit of a skepticism about whether we should be doing gene therapy when we had a bone marrow transplant option. Now, when we come to discuss a patient, they say, why can't we do gene therapy? These results, when they see how safe it is, when they see the efficacy, so obviously it has to go to the regulators. And then we'll put the evidence, as we're doing, we'll put the evidence before them. These are the outcomes with a contemporaneous cohort of BMT patients. This is the gene therapy cohort, which should be the preferable choice. So once that decision is made by regulators, then we'll know what is the standard of care.
Liz Simpson.
Elizabeth Simpson. The cases in the children that you're speaking of, you would expect perhaps a tolerance to be induced in them, because those cells will be in not only bone marrow but thymus and through the body. However, the factor 9 case that you mentioned, you're putting that material into adults and you're not affecting the rest of the immune system. And this is the factor 9 that's being produced by gene therapy is in fact a foreign protein. What evidence is there of that being tolerated?
In fact, there is a problem as far as that is concerned. So there is still an issue about tolerance to that new protein. And those individuals have had an immune reaction to the new protein, and also to the AAV vector that is brought in that carries that gene into the liver. So there's a lot of, so there have been individuals who've had quite high transaminitis as a result of that, because the protein is being expressed in the liver. And so they've had to have some immunosuppression in order to damp down that reaction. So there are, I mean, I'm not involved in that kind of study directly, but I know the investigators are looking at ways of trying to induce tolerance in those studies.
Fred, could you introduce yourself briefly?
Bassendyne, Newcastle, visiting Imperial. This may be a very stupid question, but as I understand it, the LTRs are very similar to mobile genetic elements, and our genome is sort of riddled with graveyards of retroviruses. So what do you think about 20 years down the line? I mean, do you think that there will be more instability in the genome in these cells? Because, I mean, you did say you inactivated the LTRs in your initial ones, but I wasn't sure whether in the lentivirus the long-term...
Yeah, so those are inactivated as well. So those are deleted sequences. Right. So those are no longer active.
Right, so there's no possibility that they're going to be recombination.
And there are lots of mutations that are introduced into those vectors. So the chances of recombination events and creating replication-competent virus is significantly diminished. And that's one of the safety things that we have to do, is to look for replication-competent virus. And in all the laboratory studies and in all the patients that have been treated, there's never been any evidence of replication-competent either retrovirus or lentivirus being generated.
I wasn't really meaning competent replication. It's more that the long terminal repeats can behave like mobile genetic elements
Right,
and move around, so that you might get chromosomal instability, in 20 years down the line or 40 years when these children are...
I don't think that's ever been, that hasn't been looked at in any significant detail.
Right.
But I don't know how mobile those elements actually are.
Steve Smith, who's on the board of Great Ormond Street.
Hi.
Oh, there.
Yeah, hi. Can I just, it's a very simple question as well. Your titers are still going up there. Have you reached the stage when the titers begin to go down again and the clones get less and less? And would you need to sort of re-inject or
Yeah. So our first patients are now 16 years after treatment. And so actually after about 2 years or so, there is a plateau in that T-cell development. And in fact, we haven't seen any diminution of that over that time. So, and I think that's because we've actually corrected true progenitor cells, if not true stem cells. And so there's a renewing population of gene-modified cells that is continually replenishing the immune lineages.
Final question. Oh no, Michael as well. 2 more. Yeah.
Mark Lippman, London. Great talk. I'm interested in the cost of it. My guess is this is really cheap. Relatively.
You're cheap, aren't you?
So it's difficult to know. So actually, the one marker that we have is GSK have made this vector, have made this treatment available, and that costs 594,000 euros. Now, whether other people will charge similar amounts or less, we don't know. And it hasn't yet been approved by NICE and by the NHS for reimbursement. So these are now test cases, really, as to what this will actually be priced at. I mean, it's actually going to be difficult because, we're used to medicines that are being given on a regular basis, and that's how commercial entities make their money. What price do you pay for a single intervention that's going to cure an individual for life? We don't know the answer to that, and that is a debate that will. There's an academic and clinical value, but what is the commercial value and what is the value to the NHS? And that debate is happening now.
Michael Schneider.
2 quick questions. Terrific presentation.
Whoa, short.
Quick. The quick one is, you described beautifully the evolution of the vectors in terms of safety from the point of view of insertional mutagenesis, but in Jim Wilson's early trials at Penn, the safety issue was an acute inflammatory response to the vectors. And could you comment on how that aspect has been engineered over time?
So in Jim's study, the Jesse Gelsinger case, that was a high dose of adenoviral vector that was infused systemically into the individual. So that kind of approach has now been tempered by the use of other vectors such as AAV rather than adenovirus, by the use of dosing schedules that are significantly different from what Jim used as well. So those have been built into trial development.
And the other question relates to muscular dystrophy, which was one of the features of your cartoon from 10 years ago, but which has been notoriously difficult from the standpoint of forcible expression of the wild-type protein. Could you just comment on what you see as the direction of travel in muscular dystrophy?
Yeah, I think that's difficult just because of the complexity of correcting large different muscle groups. And of course, there's the exon skipping approach that has been used using antisense nucleotides that has been developed both and has now actually been licensed for use. So I think that is still limited in the level of efficacy that it offers. And I think people are obviously looking at AAV that will then transduce large amounts of muscle, but that hasn't yet gone into clinical trials. But I think a more systemic approach is required if we're going to get multiple muscle groups corrected.
Chairman's prerogative, one last question, slightly facetious. So I noticed in the ADA trial that the CD45RA counts went down in the English cohort, and in the Indiana cohort they went up. So is that because the UK are dirtier and therefore we're getting more memory and switching from naive cells faster?
We've looked at CD45. No, so when we've looked in both the UK and the US cohort, and we start looking at more specific markers. We've done track analysis, etc. These patients who don't have any evidence of thymopoiesis start to reconstitute thymopoiesis as a result. So we can present more detailed data at a later stage, but there is reconstitution of thymopoiesis.
Okay, well, thank you so much. Really great talk. David and I have decided to allow the discussion to run, which is going to truncate the final discussion session, but so be it. So I'm delighted then to introduce our second speaker, who is Professor John Mayer, who's Professor of something at King's College London. I suspect it might be clinical immunology, but I'm not absolutely sure. But John does, again, pioneering work. You've heard a lot, I'm sure, about CAR-modified T cells in cancer. John is working with a particular population of T cells and treating solid tumours as opposed to liquid tumours. And we look forward to hearing what you have to say.
Thank you very much, Robert and David, for the invitation to come and talk today about car mechanics. So I guess I need to explain that rather cryptic title by taking you through a platform technology that's the subject of increasing interest, particularly in the cancer world, but also in other immunopathologies, as you will hear about later. This entails the use of so-called chimeric antigen receptors. So these are completely artificial molecules which you can deliver into peripheral blood T cells using, for example, a viral vector along the lines that Bobby has just spoken about. Now, we know that these immune cells are naturally designed to protect us from all kinds of potential insults, and therefore they have a variety of different specificities. Using the CAR approach, you can in essence train these cells to go after a single native target, which is engaged by this pink blob on the top of the chimeric receptor itself. Now, I've already said that our research group is known as the car mechanics group, and I guess in a sense that it indicates really what it is we spend our times doing. So we engineer these molecules with specificity for cell surface targets expressed on common malignancies, and we also engineer, of course, control cars, which may, for example, lack an endodomain and therefore lack the ability to deliver an activating signal to a T cell. So the movie that you see running at the moment entails blood taken from one of the lab staff, engineered to express a control car, and placed on a sheet of tumour cells that expresses cognate target. And as you can see, a lot of movement, those T cells buzzing around like bees around a honeypot, but no actual destruction of the underlying tumour monolayer. Whereas by contrast, if you have a chimeric receptor that's functional, you can see that the tumour monolayer is rapidly destroyed by these T cells, which engage target, become activated, and deploy their killing machinery on that particular target. Now, this is all well and good. It's good fun to play with in the lab, etc. But for many years that I've worked on this technology, it was viewed as just that, e.g. a boutique activity that would never end up having any practical consequence for anybody whatsoever. And that viewpoint has been transformed by the realization that you can make CAR T cells, which will engage a molecule called CD19, which is expressed right throughout the B cell lineage, from the birth of B cells in the bone marrow right through to the mature B cell stage. And if healthy B cells make this molecule, so indeed do malignant or transformed B cells. And the realization that one can engineer T cells to kill B cells has really transformed this field. So let me introduce you to Emma. This is at the time this movie was made, Emma was a 7-year-old with refractory acute lymphoblastic leukemia, and she was treated at UPenn with her own engineered CD19 retargeted CAR T cells. Her disease was resistant to chemotherapy. You can see how absolutely miserable she looks because she knows, despite her age, in essence, that she is in a lot of trouble. Now, her family maintained a blog, which is where this movie came from. And whilst the next entry didn't happen for a few months, Emma became incredibly sick about 2 or 3 days after she received these cells with cytokine storm, to the extent that she was admitted to ITU, intubated, supported with pressor medications, etc. And I suppose the clue is in the name. You give anti-cytokine therapies in an attempt to counteract that, which is what she was treated with. And by all accounts, within 12 hours, she was out playing with the other kids on the ward. She then went into complete remission from her leukemia. This is the next movie on the blog, about 3 or 4 months later. Little touch of vanity for the camera. A completely different girl who has gone into complete remission. And the last entry in the blog was made about 9 months ago or thereabouts. You know, so in other words, about 4 years after she received these cells. She is still alive and very, very well. She is still in complete remission. She still has CAR T cells detectable in her bloodstream, and she has no ability to make her own B cells. But that's an on-target toxicity which can be managed with immunoglobulin replacement therapy. So an acceptable price to pay, you might argue. So all of this is very much the good news, but there are many counterbalancing viewpoints about CAR T cells. And from my perspective, one of the big issues with this technology is that it does not work where it's needed most, e.g. in the solid tumor arena. Now, I've been working on CAR T cells for almost 20 years now, I'm sorry to say, and I set up a group in the UK in 2004, and back then, like now, it wasn't working in solid tumors. And I guess our thinking was, well, let's see what the antibody guys have developed as a success story in cancer therapy. And, well, two very good examples were monoclonal antibodies which target EGF receptor or HER2. So these are two receptors which form part of a network of 4 ERB receptors. And they hunt in packs, as it were, in the sense that they operate as a system of dimers, both in healthy tissues, and that network is dysregulated in a large number of solid tumors. So our thinking at the time was, okay, well, nothing is working. Let's make a CAR that really has potential to do damage to tumor cells. It may be toxic, and let's think about ways in which we can mitigate that risk of toxicity. So with those kind of thoughts in mind, we set about making what's called a second generation chimeric antigen receptor called Ti-28 zeta. So what we have glued together in this molecule, firstly, we've taken a targeting moiety, which is called the Ti peptide. And this is a promiscuous ERB ligand, meaning that it can engage many of the dimers formed by those 4 members of the ERB receptor family. And that peptide is coupled to CD28 and CD3 zeta, e.g. 2 major players in the physiological activation of T cells. So we used a retroviral vector similar to the type that Bobby has just spoken about to deliver this molecule and some control CARs into human T cells from people working in the lab, as you do. Now, having engineered Ti-28 zeta, the first question that we needed to address was, well, what exactly can we target with this chimeric antigen receptor? A Dutch group who had characterized the Ti peptide had shown that that peptide, being a promiscuous ERB ligand, can bind to all of these different ERB homo and heterodimers. So does our CAR engage those targets? Well, the way in which we address that involved taking a hemopoietic cell line called 32D, which lacks these receptors. And Mark Davies systematically introduced these receptors one by one, either individually or in every possible binary combination to recreate those dimers. Now, it's a rather busy slide, but the experiment is very simple. You simply mix CAR T cells with these targets. You look at cytokine production as an indication of T cell activation. And what you see is that the CAR does indeed recognize all of these discrete forms of ERB dimer. Now, at this point in the story, I need to Knight's move slightly and tell you about another problem that people in the CAR business have to deal with. When we do our research, we take blood from 20-something PhD students, transduce with our viral vectors, 70% gene transfer, beautiful experiments, write our paper. But of course, it's not the reality of the kind of patients that we will be dealing with, who are often elderly, with advanced metastatic disease, lymphopenic, immune compromised, etc., etc. I guess what I'm saying is that we need to confront the T cell expansion problem. And if you perform a gene transfer and you only engineer 5% of the T cells in that batch of cells to express your CAR, and you then expand those cells, you're still left with a population in which only 5% of the cells contain the therapeutic transgene. So in order to address this issue, we engineered a chimeric cytokine receptor called 4-alpha beta. And the principle here is very simple. IL-4 is an absolutely lousy growth factor for T cells. So by coupling the ectodomain of the IL-4 receptor to the shared beta chain used by the receptors for IL-2 and IL-15, we hypothesized that we could convert IL-4 into a selective growth factor just for the gene-modified cells during our manufacturing process. Now, I'm already tripping over my nomenclature. We have 2 chimeric molecules, Ti-28 zeta, CAR, targeting the ERB network, 4-alpha beta, a chimeric cytokine receptor, which we hope will allow us to grow these T cells in IL-4. So we call all of this lot T4 immunotherapy. Now, the elephant in the room, which I'm sure you're all thinking, is how can you ever possibly conceive of giving something as potentially potent as a CAR T cell to target that entire ERB network of receptor tyrosine kinases? Because after all, these are receptors which are naturally found at low levels in many normal tissues of the body. It's crazy, isn't it? And in fact, emphasizing that point even more is a case report which came out of the National Cancer Institute about 7 years ago now, of a lady who was 39 years of age and was lymphodepleted prior to receiving a large dose of CAR T cells. Now, these CAR T cells were only targeted against one member of this network of receptor tyrosine kinases, the HER2 receptor. She had metastatic colorectal cancer in which the HER2 target was highly expressed. She received 10 billion CAR T cells, and within minutes of receiving those cells, she became breathless, developed respiratory failure, multi-organ failure, and unfortunately she died after about 5 days. And at post-mortem, the conclusion was that this was on-target toxicity, whereby these CAR T cells had recognized low levels of their target, ERB2, either in the pulmonary microvasculature, which I think is the more likely explanation, or alternatively within the parenchyma of the lungs themselves. I can still remember reading that case report and the sobering effect that it had. I mean, anybody who works on CAR T cells, when you read something like this, it makes you shiver, really. And it certainly informed our direction of travel. So we began to do experiments in which we began to look at the trafficking properties of CAR T cells. And this is one such example, where we have CAR T cells that are retargeted against human MOC1, a molecule which does not exist in a mouse, as you see here. And what the important point, I think, is that if you look at these animals 3 hours after the intravenous delivery of these CAR T cells, you can see that the cells are all stuck in the lungs, which I think has significance in the context of the adverse reaction that I have just described in that unfortunate lady. Whereas by contrast, if you deliver your CAR T cells by the intratumoral approach, it's very different. So in this experiment here, Anna has injected the indium-labeled CAR T cells both north and south of an established tumor growing in the flank of this mouse. And you can see, even out to 96 hours, that the signal largely remains at the site of injection with much less evidence of systemic absorption, at least in a mouse, and at least out to 96 hours. So our thinking at this point in the story was, if you want to take a potentially toxic CAR T cell into the clinic, perhaps it might be safer to use intratumoral delivery, at least in the first instance, to try to de-risk your approach. And we also had reservations about the use of lymphodepletion. It makes a lot of sense when you're giving CAR T cells systemically to enhance their expansion, persistence, etc. But just from the point of view of primum non nocere, first do no harm, let's not lymphodeplete and see how far we can get. So if your thinking follows those kinds of lines, I guess you need to identify a malignancy in which it is reasonable to administer CAR T cells directly into the tumor. And that is why we chose head and neck cancer. I mean, if you ask people on the street, why do patients die of cancer? Well, it's because it spreads, it's because of metastasis. But of course, in the case of some malignancies, the primary cause of morbidity and death is actually locally advanced or locally recurrent tumor formation. And head and neck cancer is one such example. It's this kind of problem that these individuals have to deal with. The other reason we chose this malignancy is that it's not that rare. I mean, there are almost 3,000 deaths in the UK every year from this cancer. And that 5-year survival rate of 50% is not a lot better than when John F. Kennedy was in the White House. The other point about this malignancy is that it very, very strongly expresses the target of our T4 immunotherapy CAR-based approach. These tumors are pretty much unanimously EGFR positive, and they generally co-express at least one of the other members of that ERB network, which from a tumor's perspective makes sense because it gives that tumor flexibility to adapt in the face of an oncologist coming in with a highly targeted EGFR directed monoclonal antibody. That tumor can simply reset the ergogram, get its fix of signal, and acquire resistance to your therapeutic approach. Now, if you happen to be a patient who is unfortunate enough to be like the two individuals I've just shown, and who is deemed not to be suitable for any conventional treatment, this shows your survival prospects. I'm not sure if you can read the x-axis here. This goes out to 30 weeks. All of these patients will die within 30 weeks of being assigned to that kind of therapeutic category, as it were. And this was a very important clinical point for us in advancing the argument to the regulators that we thought it might be reasonable to try T4 immunotherapy in patients with head and neck cancer, putting the cells directly in the tumor in a first-in-man setting. Now, of course, in order to convince regulators, you need a data package showing efficacy and safety. So efficacy was initially tested in vitro. We've got 13 different human head and neck cancer cell lines here, which express a diversity of different herbograms, but they were all destroyed by these particular CAR T cells. Whereas if you take this tumor, this is a melanoma cell line, which was originally believed to be a breast cancer cell line, but it's actually a melanoma. It just expresses ERB3. ERB3 is not recognized by the CAR, so as you can see, the tumor cells are untouched. The next stage in the process involves the inevitable xenograft study. So we have an immune-compromised mouse with an established tumor burden of human head and neck cancer, which we can image by bioluminescence, and we could show that using the CAR T cells or T4 combination, that we could achieve sustained control of that disease burden. People will debate till the cows come home whether it's better to do xenografts or immune-competent models, but at the end of the day, what the regulators want to see is efficacy of the therapeutic agent itself, which in this case is a human CAR T cell. Therefore, you have to do xenograft studies of one kind or another. What about safety? We were slightly fortunate with T4 immunotherapy in the sense that the Thai peptide, even though it's of human origin, it crosses the species barrier, meaning that the human peptide can also engage mouse ERB receptors. And as a result, human CAR T cells will destroy mouse head and neck cancer cell lines. But not only that, if you take mouse pulmonary endothelium, so an ostensibly healthy or normal cell type, and you put human T4 engineered T cells on there, they will recognize and kill these pulmonary endothelial cells. And I guess putting that another way, in a sense that experiment recapitulates in a dish the toxic event that occurred to that lady that I described treated at the NCI all those years ago. And these kinds of experiments allowed us to make the case to the MHRA that we thought we could undertake meaningful safety testing, preclinical safety testing, of this approach in immune-compromised mice. Now, people have very varied views, I guess, of the regulatory process in this country, but I'm very much a fan. The MHRA are very much the good guys, and they helped us a lot in terms of designing our preclinical safety experiment, and this is what we came up with. So we have a skid beige mouse, an immune-compromised mouse, in which we have a tumor growing in the flank. The reason the tumor is there is twofold. Firstly, it allows us to test the safety of intratumoral delivery, and secondly, of course, if cytokine release occurs in the animal, that we would miss that toxicity if we did not have a tumor present. So we allow the tumor to engraft, and then 2 weeks later, we deliver our CAR T cells either directly into the tumor or into the bloodstream, the latter giving us a worst case scenario of toxicity of the investigational agent, at least in a mouse. And what we did, in order to confirm that we hadn't just administered saline, we actually monitored the tumor as well, and we could see tumor regression better with intratumoral than with intravenous, but at least confirming that the animals had in fact received the therapeutic agent. And after 7 days, when the T cells had been cleared from the animals, they were cold, and all of the major organs were analyzed independently by a veterinary histopathologist. This was a Friday afternoon, and I was delighted to receive this news that there was absolutely no toxicity. I was really surprised, actually, because I thought intravenous T4 immunotherapy would cause toxicity in the mouse. However, the PhD student who did this work was very disgruntled because she wanted to see toxicity, and indeed, she got her way, as I will explain in a moment. So at this point in the story, our thinking ran along these kinds of lines. We have a potentially toxic CAR. Let's try to de-risk by intratumoral delivery in a disease like head and neck cancer. And if all is going well, we can then think about secondary clinical trials, delivering the cells into natural body cavities in which malignant diseases spread, such as, for example, mesothelioma, high-grade serous ovarian cancer, etc. And with that kind of strategy in mind, we carried out xenograft studies in mesothelioma, demonstrating efficacy of T4 immunotherapy. And also, here's an example in ovarian cancer, where we give a low dose of T4 immunotherapy, it just dents the tumor before the animals relapse. If you give platinum, you see no effect, but if you give the combination of platinum plus T4, you see a therapeutic effect. It was in these studies, in the ovarian cancer models, that Xiaoqia uncovered the potential toxicity of this human CAR T-cell product in these mice, because she consistently noticed that if you simply weigh the animals, they always drop their body weight straight after they received the CAR T-cells. And as she dug into this further, what she discovered was happening in these mice was cytokine storm, because she could see human cytokines spilling out into the bloodstream of these mice. But I think the reason that the animals became sick was not because of these cytokines, but rather because of the fact that the human CAR T cells talk to macrophages, which are present in these mice, leading to the release of interleukin-6. And if we go right back to Emma, the little girl I told you about at the beginning of the talk, what really turned her around was a biologic named tocilizumab, which targets IL-6 receptor alpha. However, the reason that I can sleep at night is that going intratumorally, you never see cytokine release, whereas if you put the same number from the same batch into the peritoneal cavity, you do see this toxicity. The other thing we needed to go to clinic was a manufacturing process, and that was all about developing a closed process to grow these cells in gas-permeable bags. Key points to make are that we are using a blood draw rather than a leukapheresis, and we are using interleukin-4 to expand the cells over a 2-week period. I will just finish on one last slide to show you where we stand in this trial at the moment. So we began the trial in July of 2015, so we've been up and running for a little over a year and a half. We've recruited 12 patients, of whom 10 have been treated. And so far, we have not seen any dose-limiting toxicities in any of these individuals, at doses of up to 300 million CAR T cells injected directly into the tumor. As we have escalated the dose, we have begun to see evidence of efficacy of this approach, in the sense that with all of the last 4 patients that we have treated who had rapidly progressing disease before being enrolled, achieved stable disease by RECIST at 6 weeks. So I'm going to stop at that point and thank all of the people over the years, since 2004, too many to mention, frankly, who have been involved in taking this from the bench into the clinic, and I'd be very happy to take any questions.
Great stuff. Thank you very much, John. Kevin.
That's a naive question. If you have a new drug first going into man, you start off with a small dose and you gradually build up the dose to assess safety. And in the case report, they injected 10 to the 10 cells, developed a cytokine storm, and she died. And it seems to me that all of the therapies are being developed as a one massive dose and hoping that you don't get toxicity. What is against doing a dose escalation of these cells?
I did skate over the design of the trial at the end, but actually our study is in fact a dose escalation study. So our initial cohort of patients received 10 million CAR T cells, so that's 3 logs less than the patient I described earlier. And of course we're going intratumorally as well, and so far we have not seen leakage. So our idea was just to escalate by roughly 3-fold increments between cohorts. We've now started cohort 4, so we're up to 300 million CAR T cells going into that tumor. So I agree very much. I mean, I think the reason that that patient received 10 billion was that is a standard dose if you're in the business of treating patients with tumor-infiltrating lymphocytes. But I guess what we have learned with the benefit of hindsight is that a TIL cell and a CAR T cell are not the same creature.
Yeah.
Why don't you inject those T cells into the perfusing blood vessels?
Yeah, that is a possibility. I guess I thought I preferred the intratumoral approach in the first instance because it is much simpler to do. It's literally a 5-minute procedure rather than going into the feeder artery. It also is less invasive from the patient's point of view. And the other concern I would have with that, delivering it into the feeder artery is, of course, you may get some cells going into that tumor, but how do you control them coming out the other side? That's not to say, though, that I disagree with the approach that you're proposing. I think it may have merits. And actually, there are vascular delivery devices that people are developing at the moment, which may make that kind of approach even more efficient in terms of getting a better proportional delivery of your cell product into the tumor rather than, coming out the other side into the peripheral circulation.
Danny Macaulay, Belfast. Fantastic presentation. One of the challenges that I'm thinking about in terms of cell therapy is scalability.
Yeah.
You know, so clearly the sort of SCID stuff is done in Europe in a single centre. How are we going to actually scale this therapy up to deliver throughout the UK for common cancers like this?
Yeah. I mean, I'll start with a slightly trite response, and I'll say, for me, the biggest hurdle is to get this to work. If someone gets it to work, the rest will naturally follow. But addressing your comment more seriously, we're using a blood draw. I think that does make life a little bit easier than a leukapheresis. I would envisage a model where you would have centralized manufacture, so the cells traveling to a large facility where these products are being made. I think the direction of travel needs to be to remove humans from that process, to automate the manufacturing process. So you could envisage in years to come a large air hangar type facility full of machines that are literally making batches of CAR T cells for individual patients. And there are such pieces of equipment already out there. So something along that kind of model.
Yeah.
The examples you gave of the conditions were so far advanced, they were pretty gross. If you take something like mesothelioma, which may take 30 or 40 years to develop, at what point in the natural history would you intervene?
Well, I guess in the first instance, starting out, we will have to intervene in patients who have advanced disease. And generally, of course, patients with mesothelioma will have advanced disease when they come to diagnosis. So I would envisage probably that being the time that we would be intervening with the CAR T cells. They'll have advanced disease, by definition, having been diagnosed. So that's going to cause lots of issues because we're going to have a huge disease burden. Would you consider debulking these patients first with surgery? I mean, I talk to the surgeons, they tell me they remove kilograms of tumor from these individuals with standard surgical approaches for mesothelioma. Perhaps you could debulk, leave a Pleurex catheter inside you, put your cells in after that point, because I imagine these kinds of therapies are going to work best if you can minimize disease burden. So probably some kind of model along that kind of line.
Penultimate question.
As people say, another great talk. Thank you. I wondered if you'd thought about brain tumours, where you're getting, you can inject directly passing the blood-brain barrier, et cetera, et cetera.
Yes, absolutely. That's certainly another direction of travel, and people are already doing that in the US. And kind of interestingly, they seem to find that intratumoral delivery in that setting was not quite as effective as going into the ventricle, so that you can allow the cells to circulate through the CSF, etc. Quite an interesting observation that was recently made by one US group. I was more keen to go for head and neck cancer in the first instance, because I do worry if you put a lot of these cells into somebody's brain and you get a large inflammatory reaction, you do worry about how are you going to deal with that, etc. So just putting the toe into the water of the clinic, as it were, I thought head and neck cancer might be a good starting point. But absolutely, that is another key unmet need.
Final question. Do you have any clues yet about how long these cells survive? Because I guess they will start expressing IL-2 receptors, so they will get conventional survival signals, but do you know?
Yes, so we're looking at that, but I mean, we're quite early in the game, having been only up and running for a little over a year. Carl June did some pioneering studies in the 1990s in patients with HIV using so-called first-generation CARs, so not an enabled technology. But amazingly, those patients are still alive because of antiretroviral therapy and still have detectable CAR T cells in the bloodstream. And that's been very informative to people like me in terms of demonstrating the persistence of the cells and also the safety, even using old-fashioned oncoretroviral expression vectors, in contrast to the experience that Bobby described when you use these vectors to transduce stem cells.
Great, thank you very much. Our next presentation is Giovanna Lombardi from King's, who is a Professor of Human Transplant Immunology. Giovanna.
Okay, let me start by thanks the organizer for inviting me and give me the opportunity to present adoptive cell therapy, but in the context of transplantation. Just let me start, and this is a continuation of what John just presented, that I think we all agree that in the field of cancer, genetically modified effector T cells has been a huge success. In the field of autoimmunity and transplantation, we are hoping to achieve similar results in the sense that we are hoping to achieve a transplantation tolerance and to cure autoimmune disease. However, the type of cells, of T cells that we are going to use are regulatory T cells. And let me give you just a little background on these cells. These regulatory T cells are coming from the thymus. They are a small percentage, between 1 and 5% in the peripheral blood, as you can see here. And they express the CD25 molecule, that is interleukin-2 receptor alpha chain. And they also express the FOXP3, that is a transcription factor. But what is important is that these cells are key in maintaining peripheral tolerance and also are very important in preventing autoimmune reaction. And this has been demonstrated in animal model and in man by the fact that if these cells are absent or are defective in their function, it's clear that are involved in the autoimmune disease. Now, since the work that Medawar has done, and again the prize, essentially is clear that in animal model, transplantation tolerance can be achieved. This is just an example of our collaborator, Alberto Sanchez-Fuentes, where it's clear that if you transplant incompatible islet between two strains of mice, and you use a tolerance-inducing protocol, you can see that these islets are maintained forever. But what is also important, and we go back to the regulatory T cells, that if regulatory T cells are depleted from these recipient mice, then the transplant are rejected, imply that regulatory T cells are very important in the maintenance of tolerance. However, all this seminal work essentially has been a lot more difficult to achieve in larger animals, and obviously also in man. And the main reason, going back to transplantation, that is the interest of my lab, is that in health you have an equilibrium between effector T cells and regulatory T cells, but in transplantation there is a dominance of effector T cells. And although these cells are kept in check with immunosuppressive drugs, the immunosuppressive drugs are linked to morbidity and mortality. And despite the use of the immunosuppressive drugs, it's clear that half-life of transplant is not more than 10 years. And that is the reason that us and other groups in the world decide that we need to develop strategies to induce essentially transplantation tolerance. And one way forward for everything that I told you so far is to essentially tip the balance in favor of regulation, and by increasing the number of regulatory T cells in transplant patients. And the way that we started more than 10 years ago is thinking that we can expand these regulatory T cells in vitro and then adoptively transfer Tregs in transplant patients. And the idea is to take blood from end-stage patient in need of transplantation, then purify this population from the blood, as I showed you before, and then expand these regulatory T cells numerically, and then inject back in this patient receiving transplant. You can think of a very similar approach in the context of autoimmune disease. And took us, as I mentioned, more than 10 years to end up moving a manufacturing protocol from the lab to the GMP facility, and this happened 4 years ago. And essentially what the team in the GMP facility does, take the blood or leukapheresis from this patient, and then the regulatory T cells are enriched by depletion of CD8 and CD25 enrichment. And then, without going into many details, these cells are expanded with stimulation every 12 days. And what we found that rapamycin is a very important drug to maintain the stability and function, but mostly the purity of these cells. And these cells are expanded polyclonally with anti-CD3 and CD28 in the presence of interleukin-2. Then the cells are cryopreserved, and after all the release criteria, the analysis of the purity, the function, and also the sterility, the cells are then injected in patient. And 4 years ago, we started 2 clinical trials, the one study in kidney living donors in dose escalation, very similar to what John presented, and the TRIL, that is liver, disease donor, and again in dose escalation. And I want to stress here the importance of the GMP team that is in the tower of the Guy's campus, that without their involvement and their commitment, I think we couldn't achieve what we achieve today. Starting with the description of the one study, this is a sort of publicity how important are this EU consortium, and I hope that we can continue with this after the Brexit. But essentially, there are 6 centers in Europe and 2 centers in the States. Everything is coordinated by Regensburg and Gisler. And there are also 2 companies. Oops. Should I answer?
It's a little early for a question, just tell them to wait.
Hello? Somebody there. Probably was, anyway, I don't want to say. And then Milteni and Beckman, as I was saying, are the industry involved in this, and Ed Geisler is coordinating all this. And what I want to show you is our UK experience, Oxford and London working together to manufacture and also to inject the Tregs in patients. Now, the clinical trials got 2 arms, a reference arm where the patients are treated with a combined therapy of steroids, MMF, and tacrolimus, and then at the time of transplant, they receive bexiliximab or anti-CD25 antibody. And this is the reference arm that is very important, as you will see later on in the analysis of the immunological response of this patient. Then the cell therapy arm with the same combined therapy, but this time, instead of bexiliximab, the patient receives regulatory T cell polyclonally, as I showed you before. And optional is the withdrawal of MMF after 9-12 months from the start from the transplant. We are the first in the consortium, actually already 1 year ago, that we completed this clinical trial. We treated 12 patients with 4 different doses from 1 million per kilogram up to 10 million per kilogram. And the good news for us is that we can say that the regulatory T cells are safe. And this is based on the renal function of all these patients that following the transplant and the treatment with the cell therapy, essentially they all have a very stable creatinine level. And what we are waiting now for is the results of the immunomonitoring. As I mentioned to you, this will be by comparing the results of the immune system and all the parameters from the reference group with the cell therapy group that will give us an idea whether, apart from the safety of the treatment, whether these regulatory T cells had any impact on the immune response of this individual. Now, moving to the liver, the TRIL, this was one single arm, and some difference. We use ATG depletion therapy at the start, at the beginning of, at the time of the transplant, and then the patient were treated with tacrolimus and then combined with sirolimus or rapamycin. And then the regulatory T cells were injected when the immune system, following the depletion of ATG, start to be reconstituted. And the plan also here was to do a dose escalation, and unfortunately, because of the condition of the patient that had many alterations waiting for the transplant, and also that had some problem post-transplant, after long effort, we were able to treat only 3 patients with the lowest dose. And this is the reason that in discussion with the MHRA and also with the funding body, the MRC, we then decide to change the pool of the patient, and we select a patient between 6 and 12 months post-transplant when the clinical state was stable. We didn't use ATG, but we, again, used this combined therapy, the sirolimus and tacrolimus. And the cells were then injected, again, around after 3 months, and the 2 doses left, 4.5 and 6. And although here I put the 4 patients, this morning I received the good news that the 5th patient has been treated, and all the patients, the 3 previously dosed, and these 5 patients, they are all fine. That means we can conclude from this initial work with polyclonal Tregs that the adoptive transfer of polyclonal Tregs is safe, and has been altogether a success. I mean, obviously, I haven't told you all the difficulties and how long it took us to reach this point, but at least we can say that the cells are safe. And the question now is this really the end or the beginning of a new area? And I think that this is just the beginning. And this is very much based on the work that we've done in preclinical model in the lab, where we have evidence that donor-specific Tregs, namely Tregs that are expanded to be specific for the transplant, are superior compared to polyclonal Tregs in inducing transplantation tolerance. And the question is why you haven't started with that. And the main reason is because the approach that we used before with the Clinimax doesn't provide the purity of the regulatory T cells that we felt safe in the generation of donor-specific Tregs. But now we have in the GMP facility a cell sorter, this Titomax, that will allow us to generate Tregs with specificity for the graft. And I would like to spend the last few minutes linking back to what John presented. In the last year and a half, we changed the way that we generated these donor-specific regulatory T cells by using and borrowing the idea from the cancer field. Namely, we decided to use the methodology, the chimeric antigen receptor, particularly to target the regulatory T cells to the HLA class 1 that is always expressed in the graft. And with a huge help from John, we generated to construct the CAR and the truncated CAR that John described before. And the regulatory T cells were transduced with these 2 constructs. And the first thing that Dominique did in the lab, he checked that the transduction with CAR didn't modify the phenotype and also the function of these regulatory T cells. So if you just focus on the CD25, that is one of the markers, as I mentioned, for Tregs, you can see that the expression between untransduced and transduced CAR is very similar. And then Dominique, after demonstrating that in a polyclonal manner, these regulatory T cells were very similar in suppressing the responder T cells, then addressed the relevance of the expression of the CAR, whether these regulatory T cells expressing the CAR for HLA-A2 were superior in inhibiting the responder T cells when an antigen-presenting cells expressing the relevant antigen was present. And while for the untransduced Tregs, you can see that there is no difference if the responder T cells were stimulated with an A2 positive or an A2 negative antigen-presenting cells, it's clear that when the Tregs express the CAR specific for A2, they have an advantage in inhibiting the responder cells. Not much difference was observed for the delta CAR. And lastly, we move in vivo. This is a humanized mouse model that we have very well established in the lab. And what Dominique did, he transplanted human skin from an HLA-A2 individuals in immunodeficient mice. And while this skin was embedding in this animal, it generated from an A2 negative individuals the regulatory T cells, either polyclonally or expressing the CAR or the delta CAR. And then after 4 weeks, this animal was injected either with the peripheral blood from day 2 negative individuals, plus or minus the regulatory T cells that were generated. And then different parameters of skin pathology were evaluated, and this is one of these parameters, the Ki-67, that represents the proliferation of the keratinocytes. And you can see here this line green represents the proliferation of the keratinocytes when the mice that were expressing this human skin were injected with PBMC only, is very clear. And when the mice were injected with PBMC in the presence of the polyclonal Tregs, this proliferation was only in part decreased and was completely decreased, as you can see here, in the presence of the CAR Tregs, but also in the presence of the delta CAR. And this is quantified here. And you can see that for both the CAR and the delta CAR, essentially the level of Ki-67 proliferation was very similar to the mice that received just saline. And one of the interpretations for these results is, in these slides, shown by the accumulation of the regulatory T cells in the skin. As you remember, I mentioned that one of the markers is FOXP3 that is expressed by the regulatory T cells. And if you just focus on the cumulative data, it's clear that when the mice were injected with the PBMC together with the regulatory T cells, there is an accumulation of the Tregs, and this is even more when the regulatory T cells express the right CAR. Not much difference between the CAR and the delta CAR, and this is possibly explained by the fact that localization of these regulatory T cells expressing the right receptor was enough to inhibit the pathology of the skin. Now, in conclusion, I think that the CAR, I hope I show you that the CAR-mediated recognition of class 1 donor antigen offers an advantage compared to polyclonal Tregs, but also something that I think is very important, that CAR-expressing Tregs offer also the possibility of further manipulating these cells, and essentially to allow the increase in survival and potency of these cells in vivo. And altogether, and also based on published work in the field of graft versus host disease and type 1 diabetes, I think that Treg therapy and in the field of transplantation, donor-specific Tregs really holds a promise for promoting clinical transplantation tolerance. And I just want to finish by thanking all the people involved. This is just a short list about the collaborator, the people in the GMP facility, and these are some of the key players in the lab. And then I want to also acknowledge here Robert. We started probably this journey nearly 20 years ago, and now finally we move everything from the bench to the bedside. And then I want to thank also the grant body, BHF, that really provide support in all these years, particularly in the preclinical work, and MRC and the rest for supporting also the clinical trial. Thank you very much for your attention.
Ivana, terrific. Thank you very much. Questions? William at the back.
William Alazawi, Queen Mary. Thank you very much for that great talk, and I think it's a really exciting area. In liver transplantation, as you know, disease recurrence is quite an important feature and something we look out for after transplantation. You probably haven't got enough efficacy data yet, but do you think disease etiology going into transplantation is going to affect whether or not you can select a particular patient for Treg therapy, or do you think this is just a matter of controlling the reaction to the graft?
I mean, that, yes, is the point that I tried to stress at the end. I mean, the reason that we are trying now to generate donor-specific regulatory T cells is because we want that the regulatory T cells are really targeting the graft and manage to control just the response to the transplanted tissue. However, the recurrence depends very much on what. I mean, if it's, for example, a viral issue, you want to say something else?
No, I was just going to say, I'm particularly thinking of the immune-mediated, so autoimmune PBC, PSC.
Yes, I don't know how this can fit here, but I mean, essentially, if you inject the regulatory T cells, I suppose you can, yes, you can manipulate these regulatory T cells. It depends on the original disease, and that is where the CAR can help very much, or the genetically modified Tregs can help. I thought you were mentioning mostly about the viral hepatitis, where obviously if you do donor-specific, probably the big advantage is that the target will be just the alloantigen.
Jerry. So, Jerry Brown from UCL. My question is fairly similar to that viral question, which is that the corollary to suppressing autoimmunity and transplant rejection is that you might open the patient up to infection. This is another immune modulating disease that will increase the risk of infection. Do you have any data or evidence?
We got data in the one study, and that again are polyclonal Tregs, where obviously the concern that we have that if we see some infection with the polyclonal, we hope that we don't see with the donor specific. However, in the one study, essentially comparing the reference group with the cell therapy group, we saw less infection rate in the cell therapy compared to the reference. But these, again, are only 12 patients. We are waiting for the other group to join us in see whether this is still valid.
Mike.
Mike Aronstein, UCL. Great talk, Giovanna. I wanted to ask you about migration and whether you think that the Tregs are preventing effector cells from coming in or controlling them there. Do you have any data about that?
Yes, we actually, again, John presented the very nice rotating mouse. We are doing very similar work with our regulatory T cells. We have these regulatory T cells expressing NIS, that is the pump, that allowed then a different time point longitudinally to see where the Tregs go. And essentially, in this humanized mouse that I just shown, depends very much whether, and somebody, I think you mentioned, whether the macrophage are present or not, mouse-derived. We see a very different migration, but we see just in the skin. We see either very early, if the macrophages are present, or late at 30 days, that is the time that actually we sacrifice the animal to look at the histology. We see a very clear signal in the skin, in the target organ. Obviously, these mice do not have a lymph node. That means we don't know, we cannot address this question in this model, but we are hoping to do in a real mouse.
Thank you. Colin.
So, Colin Down from Cardiff. Giovanna over here.
Sorry.
Thank you. It was very, very nice. So just to go a bit further on this issue of risk, we've heard, 20 years later, Bobby's sorted his risk out. But so two things, really. One is, as I understand rightly, there are only 60% FOXP3 positive of what you put in. So why don't you generate effector cells? And the other issue is, tumors like Tregs. They love it because it allows them to grow. So is there a malignant risk here?
Yeah. I don't have an answer, but obviously one of the reasons that we are so fixated with the donor specific is to avoid all these problems. What I can tell you that, again, 12 patients is not very much, but the last patient was treated in the one study 1 year ago. And actually, all these 12 patients, not only they have a normal level of creatinine, but also none of these had any biopsy proven acute rejection, namely that whether this doesn't address your question, but address the fact that probably there is efficacy, but these patients, so far, they haven't shown any adverse effect. But I mean, it's very early, it's only 1 year. And malignancy? No sign, but again, it's very early.
Tony.
So I'm also concerned that the induction of tolerance will allow the emergence of malignant clones. And how are you going to protect against that?
Yeah. I mean, again, we are not the first one to use regulatory T cells. As I mentioned, in graft versus host disease, Blazer in the States and Diani in Perugia published this. And these patients now, they've been with regulatory T cells. Again, I don't know how long they will last for many years, and there are not malignancy there. In our case, as I mentioned again, we want to move to donor-specific regulatory T cells exactly for this reason. We wanted that the regulatory T cells just are targeting the organ and they are not distracted by other inflammatory conditions. And I think by targeting this, I mean, there is also evidence that we can have these cells localized in the organ, and I think this, in theory, should avoid the disseminated tolerance and the risk of malignancy.
Can I ask the final question, if I may? So I'm no immunologist, but what's the chance of inducing tolerance 6 or 12 months after you put a liver in, compared with at the time of transplantation?
Actually, the best, this is a very good question. The best person to answer this is Alberto Sancefuello. He's done a lot of withdrawal of drug from the liver transplant patient, and it's clear that for some of these patients, something happened. They become more susceptible to tolerance time from the transplant. That means
years, isn't it?
Yeah.
It's years, not short.
That means what we are hoping is just to, by using Tregs, to shorten this length of time and increase the pool of tolerant patients.
Great. Thank you very much.
Thank you.
And our final presentation is from Mike Schneider, who is the BHF Professor of Regenerative Cardiology at Imperial. Mike.
Great. So thank you very much, David and Robert, for the kind invitation to be here. I'm going to talk about regenerative medicine, specifically from the perspective of cardiovascular disease. And within that, I'll be specifically leading you to stem cell-derived cardiac muscle, both as a therapeutic product for cell grafting, but also importantly as an improved platform for human cardiac drug discovery. Now, the conceptual underpinnings for this are the prevalence and irreversibility of ischemic damage in acute myocardial infarction, and indeed the contribution of chronic, sporadic, indolent, ongoing cell death to chronic cardiomyopathies and heart failure states. And by contrast to some of the privileged model organisms, such as the zebrafish, which has been the recent poster child for the BHF in its Mending Broken Hearts campaign, in which amputation of the tip of the heart is followed by complete restitution of histologically normal myocardium over the course of just 4 weeks. This capacity does not exist in our adult patients or the members of this forum. Interestingly, in newborn mice, this identical capacity exists, and here's a recapitulation of the zebrafish experiment. But this capacity in the newborn mouse is lost within 1 week of birth. And whether that's because of developmental changes in the growth promoting and growth suppressing genes is not completely known, but that's likely to be a large part of it. We did combined knockouts of the tumor suppressor RB plus its paralog P130 in the heart a number of years ago, and that increases cardiac muscle cell proliferation more than 500-fold. Others have taken developmental changes in the microRNAs in the heart at 1 day versus 1 week and have pursued this as a potentially fruitful route to restart the proliferative capacity of the heart. Be that as it may, at current, the turnover in human cardiac muscle is less than 1% a year when one's 20, and less than 0.4% out in one's 60s and 70s. So the unmet need from a clinical perspective is reducing heart failure after heart attacks. Current treatments, including angioplasty stents and clot-busting drugs, merely restore blood flow to the heart, but none of these, singly or collectively, directly benefits the endangered or jeopardized cardiomyocyte. And again, from a clinical perspective, the importance of this is that each 5% increase in infarct size confers a 20% increased risk of heart failure or all-cause mortality at a year. So there's an unmet need for adjuncts to standard reperfusion therapy to rescue cardiac muscle cell number. From a 30,000-foot perspective, there are 4 overarching strategies to increase heart muscle cell number, summarized in this review of ours in Genes in Development a couple of years ago. And we'll touch on most, but not all of these this afternoon. First, I want to mention stem cell grafting using non-cardiac stem cells taken from bone marrow. Cell therapy for heart repair might sound futuristic or far off, but in fact there have been more than 70 trials of bone marrow for cardiac repair, encompassing more than 1,000 patients over the past 10 years. And the bottom line of these is that it is safe. There is, in many minds, a measurable benefit, although it's small, on the surrogate endpoint of left ventricular ejection fraction. There are no agreed outcome trials yet, but there's a large one going on in Europe currently. True regeneration, as some peppy enthusiasts thought 10 years ago, is doubtful. In other words, bone marrow does not transdifferentiate into cardiac muscle when injected into the cardiac milieu. And so the benefit, for those benefits that are seen, the mechanism is more likely to be the known contribution of bone marrow to angiogenesis and a variety of paracrine effects on myocyte survival, function, potentially dormant stem cells in the adult heart, inflammation, or remodeling. But as a further cautionary note, I would choose to emphasize that indeed there is no net benefit in the most rigorous meta-analyses of this phenomenon that have been explored to date. Consequently, there is a need to find better routes to heart repair. Now, one of those, of course, is to inject or implant cardiac myocytes from exogenous stem or progenitor cells with better proven ability to enter the cardiac lineage. And those would include bona fide, multipotent, totipotent stem cells, whether embryonic stem cells or their adult equivalent, the so-called induced pluripotent stem cell. And in addition, there has been much interesting work directly converting fibroblasts into cardiac muscle using a variety of cardiac transcription factors, and the next few slides will summarize that body of work. For those who might need reminding, embryonic stem cells are derived from very, very early embryos at the blastocyst stage, when the embryo is just a hollow ball of roughly 100 cells. And this asymmetric portion here, the inner cell mass, is what gives rise to the future embryo. When put in culture, these pluripotent cells from the blastocyst spontaneously give rise to nerve cells, cardiac muscle, or blood cells. And indeed, one starting cell can give rise to all the cell varieties in the body, something investigators take for granted in the lab every time we make a genetically engineered mouse, starting with an engineered embryonic stem cell. Now, for a variety of reasons, one is attracted to induced pluripotent cells as an alternative. These are normal adult cells, most typically from the skin or blood, converting it into something that's embryonic stem cell-like, typically using a cocktail of 2 to 4 so-called stemness genes that are responsible for the pluripotency and growth potential of the embryonic stem cell. And these have essentially identical plasticity, giving rise to cell types in the same way that ES cells do. So what are their advantages? Well, one is that they overcome the religious or ethical objections that some have to embryonic stem cells as destroying human life. A second is that they are autologous and confer less or no rejection and overcome the immunological barriers to cell implantation from allogeneic exogenous sources. The third, at least in the case of defined mutations, is the ability to generate patient-specific models of disease. And the key feature that embryonic stem cells and pluripotent stem cells have is that they follow in tissue culture the precise sequence of developmental steps that transpire in the native embryo from the time of the blastocyst to induction of the very primitive mesoderm, the germ layer that gives rise to the heart, hematopoietic system, bone, skeletal muscle, cartilage, and indeed in these transitions, the pluripotent stem cell responds to positive acting growth factors, negative acting growth factors, and growth factor antagonists that are expressed in the right time and the right place in the native embryo to be regulators of this process during normal cardiac organogenesis, as revealed through extensive knockout experiments and grafting experiments over the years. And so these typically involve the use of growth factors from the TGF-beta superfamily, including bone morphogenetic proteins and activin A as a surrogate for nodal, followed by the addition of an inhibitor of Wnt signaling, such as DICOP or other agents. Now, resulting from this, one can see here the homogeneity of cardiac myocytes that can be obtained here by immunostaining for 6 heart-specific proteins. And importantly, these cells are functionally competent, as shown by this video of human embryonic stem cell-derived myocytes made in my lab and containing a fluorescent marker of conversion to the cardiac phenotype, or as shown on the right for induced pluripotent stem cells in 3D engineered human heart tissue, again made by one of our PhD students. So one doesn't have to have much imagination to see constructs like this or like this and think that they might have potential in the heart repair by restoring sarcomeres and beating myocytes to an otherwise debilitated organ. Now, by exactly the same procedure, exactly the same logic as the creation of induced pluripotent cells, for which Yamanaka won the Nobel Prize just a few years ago, other investigators have taken the perspective of using transcription factors that mediate normal heart development and forcibly expressing these in fibroblastic cells, non-myocytes, or the cardiac stroma to drive heart formation through exogenous transcription factors. And the pioneering experiment for this was done in zebrafish, forcibly expressing the transcription factor GATA5 in a non-heart forming region of the embryo. You can see here the normal expression of the cardiac myosin light chain, also seen here, but an additional region of cardiac muscle formation is shown by this technique here. This procedure has been expanded into the mouse and even into human cells with cocktails that typically involve GATA factors, MEF2 factors, TBX5, and a number of others. And the ability to induce multiple cardiac markers by this approach is shown here. And such cells, as I emphasize, are functionally competent and even have been produced by gene delivery in vivo. Strategies similar to this also have been taken, as mentioned, to manipulate the cardiac cell cycle. Now, the approach that dominated the work in my lab for a number of years was the search for dormant adult cardiac stem cells in adult mammalian myocardia. And the list of markers that labs have used for analogous experiments is shown here. We focused on the orphan receptor, stem cell antigen 1, whose ligand is not known, but whose function in hematopoietic stem cell biology and mesenchymal stem cell biology is strongly asserted by the SCA1 knockout in mice. Others have used the hematopoietic growth factor receptor c-KIT, the so-called side population dye efflux assay, which tags the cells in bone marrow with the greatest plasticity and long-term self-renewal potential, residual expression of developmental cardiac transcription factors, green thumb tissue culture techniques like the cardiosphere or colony forming unit assay, or expression of aldehyde dehydrogenase, which is also interestingly used as a criterion for bone marrow stem cell purification. Now, having shown you that pluripotent cells like ES cells and iPS cells give rise to beating cardiac myocytes, why might one look anywhere else? Well, the reason is that besides the potential use of cardiac progenitor cells as a cell therapy product, these are of academic interest and translational interest because of their potential contribution, even unassisted, to self-repair, but more importantly, because these cells are in the heart already and are a potential target for activation in situ if we understood the ligands and pathways that drive their function. Now, through a combination of magnetic immunopurification, which we heard about in the immediately preceding talk, plus extensive flow purification with a variety of markers, we've dissected the cardiac stroma into a number of subpopulations and have mapped the highly clonogenic population in the adult mammalian heart to this set right here that co-express stem cell antigen 1, PDGF receptor alpha, and the side population dye-efflux phenotype. And I mentioned that assay before. It's a dye exclusion assay devised by my Baylor colleague Peggy Goodell when she was a postdoc at Harvard. Most of the cells lie on the diagonal. The cells that expel the dye are shifted to the left, hence their name is the side population. And by the combination of the side population phenotype, PDGF receptor alpha expression, and the reciprocal lack of CD31, we defined a population of cells with a remarkably homogeneous signature enriched for the cardiac transcription factors I alluded to before, GATA factors, hand factors, T-box factors, as well as PDGF receptor, the cognate marker of these cells. The cloning efficiency for these cells in our hands is a remarkable 30%. In a single cell deposition experiment, 30% give rise to robust clones at just 2 weeks without a feeder layer or exhaustive manipulations. And those cells are truly multipotent. When injected into the hearts of injured mice, they give rise to cardiac muscle, they give rise to smooth muscle, they give rise to endothelium. And here is a typical adult, mature, rod-shaped, striated cardiomyocyte co-expressing sarcomeric alpha-actin and the lentivirally delivered M-orange with the merged image here, isolated from a grafted heart at 8 weeks. So far, so good. But we only found 10 cells like this, in fact 10 donor-derived cells at all, at these late time points after grafting. Despite that, we saw prevention from heart failure in the treated animals. So here is mouse magnetic resonance imaging by our former postdoc Dan Stuckey, who's very happy now here at UCL. And here Dan shows the marked expansion of the left ventricular cavity in end diastole, along with marked wall thinning, and in other images, the huge infarct by late gadolinium enhancement. And in the cardiac stem cell treated mice, we saw protection of the LV cavity dimensions, protection against wall thinning, reduction of infarct size, and indeed prevention of heart failure. Well, if only 10 cells out of the 500,000 we delivered persist at 12 weeks, durable long-term engraftment is unlikely to explain the large benefits observed. And this limitation is not a peculiarity of the cells from our lab that I'm telling you about. This limitation is also true of virtually all other cells injected in the heart, including human cells similar to ours that are in 7 clinical trials around the world for acute infarction, for established heart failure, and even for congenital disorders like single ventricle and hypoplastic left heart syndrome. So one needs to look beyond what the cells become to explain the phenotypic benefits, and that requires looking perhaps at what the cells secrete. So that brings me to the last general approach to heart repair, which is blocking cell death, either by inhibiting apoptosis, necrosis, and autophagy in some combination, or by providing supplemental cell survival signals. And indeed, the latter is part of the mechanism through which our cardiac stem cells benefit the heart. And so in a series of transwell assays in which human-induced pluripotent cell-derived cardiomyocytes are seeded, and secretor cells, either the cardiac stem cells or other cell types, are in the transwell chamber, conditioning the medium that the cardiomyocytes see, we are able to see nearly complete protection of the human stem cell-derived cardiomyocytes by mouse cardiac stem cells acting in trans. Fibroblasts don't do that. Other cells from the cardiac stroma don't do that. And we've recapitulated these findings using just conditioned medium rather than a transwell experiment, and are currently embarking on a proteomic and functional genomic screen to identify the exact protective factors that confer this benefit. Now, another way to approach the problem of cardiac muscle survival is not from the outside of the cell, in terms of signals the cell receives, but from inside the cell, in terms of signal transduction cascades that are activated by cell stress and contribute to cell death. And this indeed has been a large focus of my work over the years. Typically, these experiments entail biochemical and omic studies of diseased human heart tissue, what Marty Rath would call elevator science. When you measure stuff, it goes up, goes down, or stays the same. Mimicking those changes in cardiac muscle cells through gain and loss of function mutations, and then moving the most salutary mutations into model organisms. And through this route, we identified nearly half a dozen novel pathways for cardiac muscle cell death over the years. 3 of them are shown here, involving cyclin-dependent kinase 9, telomere capping, and the telomere repeat factor 2, and TGF-beta activated kinase, or TAC1. And it was to pursue studies of this kind that I was motivated to move to Imperial some years ago because of the climate for academic drug discovery in the UK. And this work has come to focus on an upstream activator of TAC1 known as mitogen-activated protein kinase 4, or MAP4K4. It's a member of the STE20 branch of the human kinome, and it's shown here along with its closest relatives. The MAP4Ks come in 2 general flavors, the P21 activated kinases and the citron homology kinases, and MAP4K4 is a member of the latter. And the enabling data that support a drug development program targeting MAP4K4, in other words, solving Koch's postulates as related to cell death, are summarized in part here. MAP4K4 is activated in human heart tissue in heart failure regardless of cause. It is activated by defined cardiac death signals both in cell culture and in 4 mouse models, including myocardial infarction. The gain of function mutation in culture directly drives cardiac muscle cell death through TAC1 and the JNK pathway for loss of the mitochondrial membrane potential, and RNA interference protects rat and human cardiomyocytes in culture. And in the human case, we're using the iPSC-derived cardiomyocytes. I want to emphasize this last point because this is a space that has attracted a lot of activity for clinical trials, but most trials of cardioprotection have failed. And a recurring reason for this, I would argue, is that no trial in this space, indeed no cardiac drug in human history, has entered the clinic on the back of human preclinical data, such as our colleagues in immunology or cancer would consider routine or even mandatory. There hasn't been the tool with which to do this, but iPS-derived cardiomyocytes provide at least a partial entry into that space. So our route to drug development is summarized here. The first portion of this work was done with the Imperial Drug Discovery Facility, brought over by Richard Sykes from GSK when he was rector. A primary screen was done against the recombinant human MAP4K4 kinase domain. The top hits were then subjected to force field modeling to see if compounds that had no obvious similarity to one another in their planar structure might indeed be similar if one understood the charge distribution surrounding them. And indeed, 3 of our top 4 hits had a superimposable force field model. And this was used in turn as a computational probe to interrogate a library of nearly 4 million structures. The top 40 of those, which were immediately available commercially, were then screened, and we found potency equal to that we found in the primary screen, but a marked uplift in selectivity. And it was on the basis of these compounds that we moved forward with Wellcome Trust support into the past 2 years of structure-driven drug design. And this phase with our colleagues at the Cambridge medicinal chemistry firm DomainX has typically involved 8 to 10 bespoke compounds per month, design, synthesis, testing, and then another cycle, another iteration, guided in the first instance by computational docking models, but in this past year also guided by physical co-crystals of our ligands in the human MAP4K4 ATP binding site. And this is shown here for an anonymized version of the ligand, simply confirming that the ligands bind the ATP pocket of MAP4K4 and induce the so-called folded P-loop conformation. This is something that's seen in fewer than 10 human protein kinases, and we believe is responsible for our ability to achieve very high selectivity, as shown in the next slide. So the evolution and in-cell functions of the inhibitors are summarized in this slide. Here's our starting point. Here's where we are now. A marked increase in potency, not just against recombinant MAP4K4, but also in-cell protection, in this case in a rodent model. Typical selectivity is shown here, testing the compounds against either 140 human kinases in the Dundee screen or 370 in the reaction biology panel. You can see here the complete suppression of MAP4K4 activity along with its 2 closest relatives. Very, very few other potent off-target effects. None of these is a clinical showstopper, and we see specifically no off-target effects against any protein kinase known to be important for cardiac muscle cell function or cardiotoxicity, such as the tyrosine kinases that are a cause of cardiomyopathy in cancer chemotherapy. Turning to the in-cell function, we show here the rescue of cardiomyocytes, human cardiomyocyte survival, either by our starting compound in cyan or the more recent relative in purple, showing the shift to the left. Interestingly, although the stem cell-derived cardiomyocytes are immature in some functional respects relative to native adult human heart muscle, we do believe these assays have predictive power. Indeed, industry has shown that most off-target effects, most off-target toxicities would have been predicted using human stem cell-derived cardiomyocytes had they been available at the time. And the FDA and European regulators are currently in the process of preparing to demand electrophysiology in human stem cell-derived cardiomyocytes as a criterion of safety. But as potential further evidence that this system might have predictive power, we show here in side-by-side comparisons with our compounds, 2 compounds, metoprolol and exenatide, that failed to consistently confer protection in recent human phase 2 and phase 3 studies. So we argue that the expedient of testing these in human cardiomyocytes in a dish, you might have saved hundreds of millions of pounds, taking just these 2 as examples. We also have evidence for significant protection of function in the cells, even under sublethal conditions, as shown here for the rescue of mitochondrial function in the so-called seahorse assay, or as in calcium cycling in other experiments. And in the very last data slide, I just want to emphasize we've been able to use this system to progress from human cardiomyocytes in a dish back to whole animal experiments, and the current compounds reduce infarct size by 70% in mice, even given an hour after injury in blinded experiments. We could call it double-blinded because the surgeon didn't know and the person analyzing the tissue didn't know. We shouldn't call it triple-blinded because the mouse didn't know either, but that's another matter. So the take-home messages, I think, are simple. The irreversibility and prevalence of myocardial infarction make heart repair a prime target for regenerative medicine strategies. The most widely tested countermeasure in human trials, bone marrow, is unlikely to be optimal. It might work, but it's unlikely to be optimal. Alternative cell types for implantation include pluripotent stem cell derivatives, including cardiomyocytes or the precursors, and also adult cardiac stem cells from native myocardium itself. And as I said, 7 trials are currently ongoing using variants of the cells I've told you about. And nevertheless, durable engraftment is rare. The observed benefits involve paracrine effects, at least in part, including pro-survival signals and anti-inflammatory ones I haven't had time to discuss today. Besides their mere use as a therapeutic product, human stem cell-derived cardiomyocytes are an auspicious platform for target validation and cardiac drug development. And I want to thank the large number of folks at Imperial and DomainX who contributed to this, especially Michela Noseda for the stem cell work, and a large team, including Katie Chapman, for the work on MAP4K4.
Mike, thanks very much. Questions? David?
David Crossman, St Andrews. Mike, that was masterful. Thank you very much. Enjoyed it.
What was the adjective?
Masterful. You thought it was something worse, did you?
You're hard to please, so I just want to...
Yeah. Two quick questions. One is, your target selection is obviously an issue. Any chance that going back to that less than 1 week mouse versus the adult mouse will help you sort of select something that might be a real cracker to take forward? And the second thing is a more sort of clinical question, really, because let's face it, there's been an awful lot of energy put into stuff that hasn't come up with very much. And the probability is that heart failure is a very heterogeneous lumpers diagnosis. So if, when you get your molecule going, what would be the group of patients in your phase 2 trial you'd really like to do it? Would you like to do it at revascularization, established, pre-dilatation, etc.?
So let me answer the second question first, because it's quite simple. Although my clinical background and long-term research interest was chronic heart failure, cell death as a contributor to chronic heart failure, industry is evil because they're ignoring the problem, what can we come up with? As soon as we turned to drug development, we realized they're not evil, they're just pragmatic. And so our chosen clinical target as the justification for our Wellcome Trust funding, which is now in its 3rd year with another 30 months to go, is acute myocardial infarction, specifically ST segment elevation myocardial infarction, which comprises roughly 30%. And our reason for targeting those is it's a bit more homogeneous than infarcts as a whole, but also it's the more severely affected subset, so the event rate is higher, so the ability to see a benefit in the phase 3 and potentially phase 2 trials is enhanced. And whether it would be applicable to other disease groups, including non-ST segment elevation infarction or patients with STEMI not receiving urgent angioplasty in the first 6 to 12 hours. That's a matter for other trials. But what I've told you is where we think we can enter the clinic most easily. Now, if you ask the question, are there likely insights from mining the transcriptome or the proteome of the one-day-old mouse, the answer is yes. Some of the potential countermeasures that are already coming out of that analysis are the ones that I alluded to in passing. on manipulation of the cardiac cell cycle, ways that can titratably and reversibly stimulate adult cardiomyocytes to proliferate again as a route to cardiac repair. But there are likely to be others out of that, and it's a space that's watched very closely.
Mike, I think we're going to have to leave it there because we're out of time. So thank you very much. Thank you. So that brings to an end the program. I'd like to thank Robert and the Academy for working with us on the program. Thank all the speakers for our presentation. It's also the end of the Association of Physicians of Great Britain and Ireland's annual meeting, and I'd like to thank just a few people before we leave. The microphone may have given up. But can I thank Di Brown, Claire Ford, and Susan Hayden and the team for all their hard work in putting together the programme and making everything work behind the scenes. I thank the IT support, bang on cue for a new microphone and for turning on the power again when it powered down halfway through the presentation, so thanks very much. Thank the poster presentations. A particular thanks to the medical students, actually, who've done a terrific job. Can we just give you a round of applause? And we hope that one day you'll be members of this illustrious association. Fingers crossed, that's the right spirit. Can I finally thank the executive for working with us and putting together the programme? And of course, none of this would be able to happen without the secretary. So thank you very much to Colin. And on that note, can I say safe journey home, and I'll see you all in Manchester. Thank you very much.